That sounds like a plan. Let's do this. We'll get started. Well, good morning, everyone, and afternoon, and perhaps even evening if you're outside of the country somewhere. Welcome to IRC. For those of you who are new to this space, thank you for coming in today. You probably have heard of us through some sort of a buzz catchword of data informatics and rehab somewhere in the middle. But we really want to foster rehab individuals, professionals, or non-rehab, doesn't matter, who are interested in growing in the informatics space and in your projects, in your work, in education, etc. So welcome again. We do have a pretty full agenda, so why don't we go right into the announcements? Oh, before we do, if you are new to this IRC and you haven't had a chance to fill out a profile, we just simply ask, what are your interests? What's your background? We want to get to know you. And, this is a community of professionals. We want to collaborate. So please fill in those profile if you can, or if you could reach out to Madeline Rotosa, or just email us if you got into this space already, you probably already have that. But if you need to get a reach of us, you can get a hold of any of us. So just few upcoming conferences. There's PT Future Summit that's happening in about a month in Washington, DC, where we're talking about lots of things that are bubbling up. It's been bubbling up: digital health, AI, machine learning, and how does that actually translate into the PT space in our profession? It's going to be a really amazing conversation. The one-day summit. Bob, do you have anything specific you want to add to that? Yep.
No,
And
just
CSM,
anybody who's going to be there, we'll see you.
yeah.
Maybe if you want to put it in the chat, you can just tell us who's there. So
thank you, Bob. And CSM 2024, if you had submitted your proposal, education platform, whatever it may be, if you had, I know this particular year was really high volume of proposals. So please let us know if you got your proposals accepted, so we could make an announcement to the entire group. ELC, Education Leadership Conference, is also coming up in a few months in Philadelphia. There's this annual AMA, American Medical Informatics Association. They have this annual symposium that's coming up. And Learn Network, they are part of a learning health. They have really a good, solid resources that are available for anyone with, particularly on the research side and education side. In fact, I know that they have a recording sessions today in chronic care management. So if you're interested in learning about that, dig into the resources, please look at the website there. And then there's a PROMIS, Patient Reported Outcome Measurement Information System. It's more of a quality life measurement group. There's a collaborative. They're always looking for more representative from physical therapy world. Bob, anything else here before we go into the website? Oh, the resource.
yeah, just real quick, two different, I'm going to share my screen if it works, Sam, real quick.
Yes, let me just stop here.
During our call last month, we talked about a couple of different things. And Matt Elrod, thank you for putting the framework of this together. The first one was just different contacts and connections that we have. Stephen, this came a little bit out of the conversation that we had about some of the policies. But the first column basically talks about the organization, then who's your staff contact, who's the contact within the IRC, what the agenda is of the organization, and then any resources that they might have, and any notes or comments that you have out here on the side. We will get this link around to everybody just so that you can fill it out and put any information. It begins to help us know who's connected where and related to rehab informatics, how we can use that for advocacy and such. And with that, real quick, I'll just mention the two things, and I think we talked about these last time. The first one is, the first one's the second one here, which is the ONC HTI-1 proposed rule. And only bringing that up because there's a lot of stuff related to algorithm transparency. The comments for that are due on June 20th. If you were to come in here, you can click on that and get there. But again, just so everybody knows about that one. The second one is the USCDI plus quality data elements. Matt, I'm not sure if you want to touch base on this at all, but this request for information feedback is due by June 30th. And I guess the biggest thing that I'll share, as I understand, there's a category related to functional mobility and another related to self-care that may be relevant to us. Matt, any additional thoughts there?
Yeah, the only thing is this is just related to, again, quality measures and using data standards associated with that. So they're just trying to identify what data elements should be included in the data standards process to help with quality improvement activities. So that's just kind of the, elevator speech of what it is.
Great, and we'll send these out through the list that we have on the inside here in the informatics group. So that list comes from the folks who have filled out the form on that homepage. So you click on that, join us, the profile, and that's where we get the email and everything. Sam, I'm going to stop sharing my screen and go back to you.
Well, maybe you can just keep it. The
sorry,
next thing
go
I
ahead.
want to talk about is actually the website, and you were on the website. So
all right, fair enough.
Yeah, just a brief update. I'm going to put a couple links in the chat. The new website link, it's no longer just a Google link. It's rehabinformatics.org. And if you have a profile that you put on there that you don't want on there anymore, like you don't want it to be public anymore, you just email me and I'll take it down. And then we also have organized all the videos. You can link from them from the website, but they're also on a YouTube channel. So you could go there directly if you wanted to. So that's about it.
Yeah, thank you so much, Madeline. And really appreciate your support and your work. It just makes it so much cleaner. And we hope to continue this grow in this resource space. So please reach out to us. Let's collaborate. Let's put the more resources, more like hub would be a great opportunity for anyone who are interested in this space. So without further ado, Jen, would you like to go ahead and introduce Chris for us?
Sure. Chris, before I do that, do you want to test your audio again?
Yep. How's it working?
Excellent. All right. Again, I'm Jen Kraft. I'm going to introduce our speaker for this month, Dr. Chris Hoekstra, PT, DPT, PhD. Chris received his PhD in biomedical informatics from Oregon Health and Science University School of Medicine, his Master of Science and DPT degrees from Pacific University, and his undergraduate degree in biology from Willamette University. Go Oregon. He is board certified in orthopedics and fellowship trained in manual PT. He's worked as a PT, a clinic director, and more recently as the Chief Clinical Transformation Officer for Therapeutic Associates, Inc. In that role, he's overseen the company strategy related to the use of organizational data in business and clinical decision-making, quality improvement efforts, and value-based care initiatives. Chris is also an assistant professor in the Department of Medical Informatics and Clinical Epidemiology at OHSU School of Medicine, where he teaches courses in organizational behavior and qualitative research. He also continues his research now focusing on facilitators and barriers to the use of informational aids in clinical and business practice. Chris has applied his informatics training as a consultant to multiple healthcare orgs relative to health IT interoperability and was a member of the PT Outcomes Registry Scientific Advisory Panel. He's also worked as a consultant to large healthcare systems focused on data analytics strategy and improved organizational use of information for decision making. Chris has dedicated his career to improving clinicians and business leaders' use of information in their daily decision-making. His goal is to refine the socio-technical framework that integrates information systems with organizational strategy, workflow design, and information presentation to allow practices and providers to thrive in the coming value-based healthcare landscape. Chris also said he's just I think you maybe said you're a data geek who just wants to improve qualitative use of data in healthcare. So I could have just said that, I think. But I will go ahead and hand it over. Thanks, Chris.
Awesome. Thanks for that. Yeah, I guess to start off, I feel awkward presenting to this group because you all can present and have amazing insights. So hopefully you gain something from me. And I kind of take a weird journey. And so I hope this is relevant. But for me, it's been my informatics journey. So hopefully at least pieces of it resonate with you. So I'm going to go ahead and share my screen here. If someone can confirm, you can see my screen.
Yep.
You can see it? Okay.
Yes.
So Jen had asked me a month or so ago if I'd be willing to talk, and I said, well, sure, but what do you want me to talk about? So I gave her a few options and kind of settled on this concept of a work we're endeavoring on now in Therapeutic Associates, this concept of building a transformation management office. And then really why? It's to really take data and move it to wise action, but really in a socio-technical ecosystem. So the goal of all informaticists is to take data and translate it into action at the right point in time by the right people. So this image here, if I ever get a tattoo, this is probably the tattoo that I'm going to get. The image in the middle of kind of the brain plus the computer is greater than the brain on its own. This is from Chuck Friedman, kind of one of the founding members of, or founding thinkers of biomedical informatics. And really it was a correction of initial informatics thought that a computer was better than a person. We recognized when you implemented EHRs that, well, that's not true at all. But a person plus a computer is better than a person. That's truer. But what I've put on top of this is a diamond by Harold Levitt. So he was a management psychologist in the 50s, 60s. This came out. And this is the concept of a socio-technical ecosystem. And everything through all of my training, I didn't see this coming when I started, but where I ended, I said, this is what it's all about. It's actually the interplay between the people, the organizational structure in which they work, which kind of creates the sociology, that's just organizational behavior, and then the technology that they interact with every day, and then specifically the tasks that you're asking them to do. You change any one of those variables and you change the impact that the computer has on the person and ultimately the outcome. So it's not sufficient to give cool technology. It's not sufficient to give cool information. It has to be contextually relevant and it has to be applied and the people actually have to use it. And that's really where my PhD training and initial research got me. And that's where a lot of my work is now, on understanding how do you get people to do the stuff and use the things that you work so hard to create. So really, I'll go give you a little overview of what I want to talk about today. So I'll focus a little bit on my role, my current role and past roles. And then the biggest meat of what I want to focus on is how me becoming a social psychologist, or AKA an informaticist, shapes my passion and perspective and really my worldview. And I hope you come away from this saying, as an informaticist, whatever that means to you right now, we really can't get away from our role as a social psychologist. That yes, we love computers, yes, we love information, but at the end of the day, you need to understand what makes people tick and how to motivate people to change their actions. It's all about organizational change and transformation. I'll talk a little bit about how my research has shaped my work today, and then we'll talk about current and future work. I put this infographic up here. There are tons of them out there. If you've looked at the typical informatics graphic of kind of translation of data down at the bottom up to wise action at the top and information and knowledge in the middle, I think that's great, but this, among others, is more of a focus on what a learning health organization is. You have to identify knowledge gaps. You have to understand the context and the why around those knowledge gaps. You need to then find the answer to fill the gap, but then more importantly, you need to figure out the right way to integrate it, the right way to shape change, how to measure the impact of that change, and then refine your approach. I'll give a nod to Stephen Hunter. I saw is on the call today. A lot of this, we've done a lot of learning from the Intermountain Group over the years and trying to apply what they do so well and trying to apply it in more of an outpatient setting. And so I think we can all learn from one another. And this is my tag. I am not the world's smartest guy, but I steal information from everybody and I'm an assimilator. So why make my own knowledge up when I can take from really smart, brilliant people that are doing it well and assimilate it under new models? That's kind of what gets me excited. So with that, kind of what is my role in Therapeutic Associates? Just to give you a little org structure of where this can fit. This is just how it fits in ours. And I've created this over 10 years of playing in the informatics world. So it didn't always look like this. If we just look at our organization structure, we have the CEO, and under that, the typical C-suite. So my role sits under there as the Chief Clinical Transformation Officer. We also have a Chief People Officer, which oversees really the new version of HR, not just people hiring, firing, recruiting, but how do we motivate people? How do we understand the motivations of our people and the facilitators and barriers on their life? So we work really closely together because my work is so socially and psychologically tied that our roles are really intimately connected. Then we have your traditional CFO and COO. I didn't put all of their downstream just because the slide's not big enough, but what do I oversee? The biggest focus of my work is I oversee our Department of Business Intelligence and Innovation. So that has kind of two main tenets right now, an arm of business intelligence and analytics. So that's all of our databases, data visualization tools, ETL processes to kind of refine all of our data streams into a place where we can get actionable insights. Another part of that group is really understanding what are the questions that our different key stakeholders have, and then designing solutions that meet those questions. We also have aligned very closely with that a process control and innovation department. So in that, really, we own the EHR process, or really where strategically are we taking that and how do we optimize that? The practice management system, because that's so intimately tied to EHR and the patient flow. And then all the interfaced applications. We don't have just one EHR and we live there. We live by interfaces. And so we have a ton of interfaced applications. So we handle how those interfaces happen and how do we get the data from all of those different applications to a central data lake so that we can do a process of transforming that into, again, actionable insights. The red part down here is what we're working on building now. I actually have an individual that's working with my group now. Kellen Robinson is on the call today. I invited him so he can check me if I'm missing anything here. But we're trying to build out this transformation management office, or historically would be known as a PMO, a portfolio management office. This has been darn near a 10-year endeavor for us, and that just underpins the psychology, sociology piece of this, organizational change. It doesn't move quick. In that, we have project management as a focus. We have organizational prioritization. So how do you pick projects and use your strategic anchors and kind of the goals of the company to guide which projects you pick? And then once you pick them, how do you manage them and make sure you get them done on time, on budget, and with the right deliverables? And then also a big one for us that we have not at all solved for, but we recognize that we're the answer for, is resource management. So as you're doing these projects, we only have so many hours and so much effort from our folks in a day. So how do you prioritize those very limited resources to the areas of highest impact? Okay. I forgot to mention when I started here, I like to talk. So if you want to interrupt me, please interrupt me. I can't really see hands. So maybe Sam, if you can moderate, if a hand goes up, chime in, and I'm more than happy to stop and sidetrack here.
Yeah.
So what drives the department that I oversee in my role? This is a mission statement that we wrote when I kind of took over my role a couple of years ago. So TAI embraces clinical transformation. I've underlined some words here as the continual and proactive reimagination, or put another way, we're the curiosity police. Like if you're not curious, you're not growing. So we are forcing folks to just challenge the norms and to ask yourself, is that really where we want to go? Can you change that for the better at all? And not in an accusatory way. That's what we do as informaticists, is always try to optimize of processes and information systems, but always to serve. At the end of the day, we sometimes lose sight of why we're doing what we're doing, and we just make cool stuff for cool stuff's sake. We serve key stakeholders. So we want to serve them more effectively and efficiently the needs of our providers. So that's a key stakeholder for us, our clinical team, and our patients. Now, certainly some of my work is on business leaders. I serve our finance department, CEO and COO with reports. But at the end of the day, our department is really at the mercy of how do we best serve our clinical teams and our patients. We can't lose sight of that when we look at what we do. So historically, what we saw in our organization, I think we see in a lot of organizations, is you get this bit of a desire to try to balance. So you balance the needs of the patients with the needs of the providers, and you think of it as this teeter-totter. If I give the patient too much, it's at the demise of my providers. If I take away some of the productivity requirements or other things on my providers, and the patients suffer. So let's just work to balance them. I told you I'm not the world's smartest guy. I definitely steal from folks. About 10 years ago, a book really came in, it was a Harvard Business Review article, but this concept of the three tensions, I'd encourage you, if you've never read the article, it's a free Harvard Business Review article. It's older now, like 2007, but they really challenged the business contention of trying to always balance things. And they looked at balancing the future versus the now, profit versus growth, the whole of the organization versus the parts of the organization. Those were kind of their three areas, but they basically said you shouldn't try to balance them. You should find ways to optimize all of them. When we try to balance them, we get this concept of satisficing. This came out of my informatics training. It's really a computer science, computer development term. And satisficing is the combination of sacrifice and ultimately sufficient. And you don't want either. Basically, satisficing is settling for the least bad option. And that doesn't sound great at all, right? This also, I was moved, there's another book on negotiation that's called what's it called? Never Split the Difference. And I think these both actually work on the same premise. If a husband gets dressed for an evening out and he wants to wear brown shoes with his black suit, and his wife says, you shouldn't wear brown shoes, you should wear black shoes. The satisficing answer would be, or the split the difference answer would be, he's going to wear one black shoe and one brown shoe, right? Because ultimately everybody's happy. You're each wearing one of what they wanted. But the problem is that's satisficing. That's worse than having picked one or the other. And so really what our goal should be is to work to optimize those key stakeholders, not feeling like they're in this polarity with one another, but how can we find ways to play with the process and come at it from a different angle to optimize all of those. So that's really the work that we try to focus on. So my career journey, I put this up here and it's probably gonna make you dizzy, and it makes me dizzy. My career trajectory to an informaticist was not a straight line. So I came out of PT school, worked in a hospital system. I knew that I wanted to be good at manual therapy, so I went into my residency program through Kaiser Hayward, and I wanted to be an amazing manual therapist, and I wanted to teach. I knew I had a heart for teaching very early on. Came out of my residency and started work with with therapeutic associates as a PT, but ultimately I went to the NIOP system to finish my manual therapy fellowship because I wanted to teach manual therapy. I was convinced that manual therapy would get all our patients better, and if I was just a better therapist and learned more and packed more into my brain, all my patients would get better. And if I could just teach people how to do that the right way, all the patients would get better. We know that's not true. And so we got to the middle of, I went through my fellowship. I have taught with the NIOP system, recognizing that was insufficient. Probably about 3 to 5 years into my career, really became infatuated with clinical outcomes. How do we measure it? We had a measure tool that was not standardized, was not validated and reliable. I recognized it was garbage in, garbage out. So took a sidetrack and did some research on that to try to validate it. Got involved with the PT Outcomes Registry probably about 10 years ago. It's been a long journey to now it's no longer around. And so thought that was the answer. If we just put all the data into a database and then you just put the database in front of people, everyone's going to get better. It's going to be awesome. That's not true either. Around the same time, I found the term informatics. So I'm like, this is it. I need to go study informatics. OHSU had a renowned program, one of the pillar programs in the informatics world in medicine. I said, if I just study that, I can build clinical decision support tools and algorithms on the back end. If I just put them in the EHR and give good information to the therapists, then they'll make good decisions. And I went all the way through my master's, and I did a master's thesis that basically built an algorithm that predicted patients that were going to do poorly following total hip replacement using a summary of the literature. But there was a qualitative piece at the end. I took that to physicians and said, great, here's my model. What did I miss to make it better? And they had a few things, but they said, no, this is actually really good. This would really help. And I said, wonderful. One of my questions is, would you use it? And they all resounding, no, I'd never use it. Well, why wouldn't you use it? I'm not incentivized to it. It's not integrated in my EHR. I have competing prioritizations in what I do. So I'd spent, at that point, 4 years working on my master's, finished my master's thesis and said, I made a mistake. Actually, it's not at all about what I just studied for the last 4 years. It actually has everything to do with the facilitators and barriers that allow people to use these tools that they recognize are very good, but they'll never use in their practice. So I was fortunate enough to get a postdoctoral fellowship to be able to study qualitative research, I had a great qualitative researcher. One of the big names in qualitative research and informatics was my research dissertation advisor. Got to work on her research team. And that really started my journey to become a social psychologist. But it took me to get to my PhD to realize it was about the people and it wasn't about the technology. So bad on me. I put these other things on here in addition to TAI because I've worked with a consulting company where we go into large healthcare systems and we say, great, you want to do analytics, tell me about what you want to do. And they'd say, I want to do AI. And you'd say, great, why do you want to do AI? Well, because I need to answer this question. Well, cool, that question could be answered with a simple calculation. Why do you need AI to answer that? Well, because everyone's using AI. So that's just, organizations tend to maybe not match the technology with the questions that they have. And I saw this at the highest level. Some big name healthcare systems were having this problem even 5 years ago. And then the last piece, I do some work with a startup company now here, because you see this in the startup world too. We get data. If we just put more data in, it's going to be amazing. So my work with them has kind of been, put the data in, but what are you trying to do with it? And maybe you want to organize your data a different way so you make sure that you're getting the outcome that you're shooting for. So I'm not really a data geek. They have lots of biomechanists much smarter than me, but I can help them to say, I'm basically always the scab picker. Why are you doing that? Why do we need that data? Who's going to use that data? Which I think is oftentimes a missed question. So that's kind of my circuitous journey that got me here. So I'll pause there. Any big questions? I'll come up for air, and then I'll move on to kind of where I am now and what got me here with my research.
I have a quick question, Chris.
Sure.
Out of all these places that you worked on, aside from the current position, which one would you say had the most fulfilling kind of time? Maybe it could be sometimes like a painful experience, but you learn it from that and you're like, that was really good. Would you be able to share a little bit of that?
Yeah, probably two. So in my work at OHSU, I was part of a multidisciplinary team that looked at the safety of medical scribes. This had never been studied before. And two things came out of that. One, so we use this approach called rapid qualitative inquiry. It's a little different than typical ethnography, which is a little longer term. We go really fast and it's iterative and team-based. And so it was difficult to kind of, we have physicians, we have informaticists, we have ethnographers. I was a PT, so I'm like, what's my role? But to learn how the team has different perspectives and how we can go in and observe, how we can interview folks and come back and synthesize that as a multi-collaborative team, and how to make a collaborative exercise out of inference creation. I think that has shaped all of my work. And to learn from experts in the field, I was so very fortunate to be able to be a part of that team. So I think that's one. That tied to, at the time when I started, I said, why aren't they scribing in PT? We have the exact same problems. So we started a scribe program. I trained the scribes. I paid the scribe and I farmed them out to a few of my clinics as a study. And it's a people problem and a process problem. Some of the clinics did great with it. They loved it. And it was the answer to their prayers, just like we saw in medicine. Some didn't use them at all. They thought it was a hindrance and this person's just bugging me and they're just messing with my flow. Why are you doing this? And others were trying, but they struggled. So again, it solidified in my mind that it's a technology, a process problem, and a social problem altogether. So I think that's probably the biggest one, tied then to my work that we're working on now.
Thank you, Chris. Yeah, that's great.
Great.
I have a question related to that.
Yeah.
How do we teach young PTs interested in informatics that point? The piece about it being more than just technology.
Yeah, I think so. I was moved very early in my career. I was infatuated with the clinical reasoning process. And in my mind, I was trained in the Maitland School of Thought. So if you just do a thorough enough subjective examination, your physical examination is very easy and it's fairly algorithmic. If this, then that, if this, then that. But more than that, when I started to mentor, you're like, that breaks down because it's bigger than that, right? So I think if we can tie it back to the clinical reasoning process, you can have an algorithm, you can have a clinical prediction rule that tells you one thing, but when you take that clinical prediction rule and put it into a real patient environment that has now your experience, the patient's background, all of those biopsychosocial issues that touch their condition, all of those social determinants of health that influence how you're going to be able to work on it, you realize very quickly that that's only one piece of it. So I think if you tie it back to the reality of patient care, it's no different. It's a key piece, but it's not the piece, even though technology is cool. And I think changing the way we work is never going to change the fact that it's only part of a bigger thing.
Thank you.
Yep. Any other questions? All right. So I'm going to geek out here for a second. So bear with me. So what I'm really fascinated with, what my research focused on, and now my work focuses on, is this concept of planned behavior, or the theory of reasoned action. They're kind of two theories from back in the 50s or 60s, these psychosocial models of why do people act the way that they do. I am not a psychologist, but I understand the application at the organizational level. So in a broad stroke, basically what happens is there are a series of internal and external factors that influence a person, and that influences what we call their behavioral intention, what they intend to do. And with planned behavior, if we use technology, if we get the right internal and external factors together, that'll make them want to use the technology. And if they want to use the technology, they probably will use the technology. Or put another way, let's use exercise. If I have enough internal and external factors, I'm going to want to exercise. And if I want to exercise, I will exercise. Now you see where it breaks down, right? Because just because you want to exercise doesn't mean you will exercise. And there's lots of factors, that both internal and external, that influence whether you want to exercise. And so how do we study that? But that's really at the heart of what I look at with this concept of technology adoption. Now, again, I steal from all the smart people. This is really well studied in the concept of social economics. So whether it's nudge, this has been around, the Obama administration used this a bunch, and you could kind of see it in how the government changes the way that they try to move policy and get the population to move based on some of these frameworks in nudge. Daniel Kahneman's think fast, think slow. So just understand how people make decisions. Sometimes it's heuristic and quick. Sometimes you're overanalyzed, and how can you move that process? Dan O'Reilly, this is probably the one that moved me the most, is predictably irrational, that people oftentimes behave what appears on the outside very irrational, but if you walk it back, you could actually predict it. Mathematically, you could predict it if you understood the right factors and the context in which it's applied. And then I also put this concept of never split the difference, where this is really a negotiating book on the outside, but on the inside, it's you need to understand the motivations of the person. Or put another way, for you to be able to negotiate effectively, you need to empathize with the person that you're negotiating with. I need to understand intimately what it's like to be them. And more than that, I need to understand all of influences on their life. If I can do that, I can move them, whether it's move them to negotiate them to come to something that we can agree on, or whether it's to move a behavior that I need them to do to get an outcome that we're looking for in an organization. So again, the stuff that I show you here is not unique to me. I'm not a brilliant person. It's just I take from here and apply it. There is a framework that I used in my research called the Unified Theory of Acceptance and Use of Technology, UTAUT. That's all I'll say from here on out. There are lots of technology adoption models. In fact, there's one called the technology adoption model, which is similar to this. It's basically that internal, external factors go to a planned behavior goes to behavior. With respect to technology, research has shown that if a person thinks that using this technology will make their life easier, that's that performance expectancy, or they think it's going to be easy to use the technology, or they think that people that they put in high esteem think that they should use that technology, or the organization puts in facilitating factors to make it easy for them to use that technology, then they're probably going to want to use it. And if that, they're probably going to use it. Now, the weird one in the middle is habit comes on. You could have all these other factors, but if your habit is just to heuristically do this, then you can hijack the whole process. But this is a structural equation modeling. So I use structural equation modeling to mathematically study this. And now we can take, these are called latent constructs. These are things we can't actually measure directly, kind of like IQ. You can't measure IQ directly, but you can ask a battery of questions. And from that, you can infer this latent construct of IQ. So we use structural equation modeling to put mathematical values to these. And then just like a regression model, we can put coefficient weights to figure out how much they impact the outcome variables on the right side. So geek out there. One more level of geek out is Viswan Venkatesh. He's the chair at the Virginia Tech School of Business right now, but he created this model initially. But what I appreciate about his approach is he made the model, and then for the next 10 years, he kept looking at how to disprove the model or change the model. And so this was a 2016 adaptation where basically he said, you can take that model, but if you apply that model to people of different ages, or you apply it to people of different genders or different experience levels, or in a different task context, or the same task in a different organization context, the model is going to behave differently. So you have all these contextual factors that impact or mediate or moderate, depending on how we want to put them in, how the predictor variables on the left predict the outcome on the left, or sorry, on the right. So what was intriguing to me is this had really not been studied in physical therapy well. A few studies on some other areas, but never really on the area that I was interested in, and not in detail. So what I did, this was my study model, and sorry to geek out a little bit more, but we basically in blue have the UTALT model. What I then did was had a mixed methods approach. So I did a qualitative study first, where we went into managers and said, why do you use the quality? It was about quality was our focus. Why do you use technology to manage quality? Why do you use it? Why don't you? And we really created 3 new constructs. The construct of how they gained knowledge in order to manage, the concept of their perception of personal agency, how much control they felt they had in the matter, and then the organizational pressures put on them, external to managing quality. And then I was also interested in these mediating factors of age, years of service, and gender. So basically my study, and we're not going to get into that, but this kind of gets to the heart of what I'm looking at, is this is the social influence of a model that works very well, that has very great R-squareds. But when you put these mediating or moderating factors in, it totally changes how the model's going to affect. And that's because of the first slide that I showed you. It's the context of the task and the organization, personal characteristics, and the system itself that all influence whether a person's going to use the technology or not. So when I did my dissertation, I knew that I didn't want to just do an academic exercise. I wanted to apply it to real life business. So I made sure that I went to the business school and asked a business leader to be on my dissertation committee. And I was fortunate who I got. As I pitched to him this concept of rapid qualitative inquiry and what I was going to try to do with the qualitative portion of my research, he was like, that sounds a lot like design thinking. And I said, what's design thinking? Because I'd lived in my informatics world. I've never lived on the business side. Design thinking is used in software design or tech, usable tech design. And really, it's focused on the concept of understanding your client's motivations, their barriers, and their goals so intimately, and then challenging those assumptions very systematically, refining what the actual problem you're trying to solve is based on what you learn from your end users, and then iterate to create a product that when you put it out, the person's like, where have you been all my life? Like, how did you know me? Apple does a very good job of this, right? When Apple puts something out, you just intuitively know where to poke, and you're like, I didn't even know I needed that app, but I can't live without it. It's because they use this process. Contrast to Dell in the 1990s. Dell would say, we have an amazing computer with more RAM than anyone else, and it can process so much faster than every computer, so you should buy it because it's a really good computer. And they were trying to convince you it was important, where Apple's like, I don't need to convince you because I live back here. I actually know what motivates you at your limbic system, at your hindbrain, midbrain. That's really what motivates. And that's a concept of that social economics. And so the concept of this is basically you start with one assumption of what the problem is. And if we're linear thinkers, we think we want to go from problem to solution in a straight line. What we really have to always challenge is the solution I'm about to do a desirable one? Is it a viable one? Is it a feasible one? And so we use this concept of a double diamond. So first we need to say the problem at hand. So this is just a collaboration exercise, not unique to design thinking, but where I think the problem is, I'm best served if I can get a group of people with different perspectives to say, is this the real problem at hand? And we first do a diamond exercise to say, this is what I think the problem is, but someone else will say, from my perspective, I think this is the problem. Someone else will say, from my perspective, I think this is it. You widen it out to all the possibilities, and then collaboratively, you collapse it down to say, we can all agree that this seems to be the most pressing problem. So now we've moved ourselves on where the problem is. And now we do the same thing over to solution. So based on our newly understood definition of the problem, I think this is the solution. Great. I think this is it. I think this is it. We widen it out, and then we do an exercise to come together. That forces us to be collaborative in nature. I think this fits very well with the DEI push that's happening right now, because it's the same thing. You basically challenge your perspectives and know that your perspective is your perspective and alone. But when you get other perspectives in the room that come from a different angle, a different background, different motivation, you're going to have a much better outcome than had you done it on your own. We also will try to balance that with change leadership. So I'm a big disciple of John Kotter. So he's from Harvard Business School. And there are lots of models of change leadership, but he's nice in that he gives you kind of these 8 steps to go through. I would argue that the 2 that we typically fail on are number 1 and number 4, because we as PTs and informaticists are solution oriented. We don't want to get stuff done. So we find a problem and I want a quick solution and move. The problem with that is if there's no urgency, urgency is the biggest motivator to change. Until you have urgency, you're going to have to work really hard to get people to create enough inertia to want to move. And then oftentimes it can be a great solution and in everyone's best interest to make this change. But if the vision of why you're doing this is not clearly and overly communicated, you're going to have a really hard time getting the organization to adopt whatever it is you want them to adopt. This is very related to Simon Sinek's work, the concept of the golden why and all of that. You basically, if an organization can understand the why behind it and understand your passion, that you're in it for them, and you can help them to understand, you understand all the barriers and facilitators in their life so intimately that this solution is in their best interest, they're going to naturally want to step with it because they know you understand them and it's better for everyone. So last few slides here, and then I'd love to just have some dialogue. This is some of the work we're doing now to try to move that. So this is a report that I just released to our directors last week. I took some of the details out of it, but this is a finance start here report. Historically, our financial department has spit out a financial statement once a month that said, here's everything to do with your finances and good luck with that. And I went to our CFO and controller and said, what are the top 5 questions that people come to you that you roll your eyes every time it comes? Well, how about I make a dashboard that answers that? And so we helped them to focus on some key areas. This one, I won't go into the nuances of it, but as we presented to them, we said, as you look at your finances, start here, and there's really 4 outcomes. You either are missing on revenue, and if so, go over here. You have an expense problem, and if so, go over here. You might be doing everything right operationally and still missing on revenue. So that's a revenue cycle problem. So you might want to go over here, right? And then the last one is just there's something else going on, and then we might actually look for a data problem. But that's the least one. Most of us, though, when we were finding our directors would start over at the right at profit margin, and they'd look at the profit margin. If it was good, they'd say, woohoo, high five, and move on. They wouldn't learn. Worse, if it went down, they would say, but I worked really hard last month and my profit margin was off, so the data must be wrong. Everyone said that. So this was helping them to kind of say, challenge that assumption. Maybe that's the 4th option, but let's go through the other 3 more probable ones first. And then if those all don't pan out, then we'll go down this road. We'll see how it pans out because I just rolled it out last week. More pressing kind of in my world and more close to my heart is on quality. So we have a quality report. We call this the measure to action team. So we actually have a team of 10 therapists who are full-time practicing PTs, but we've trained them to be mentors to help people look at their dashboards on quality and then make meaningful systematic changes to those. They have a one-on-one at the elbow support. So we look at things like your NPS score, patient-reported outcomes we've looked at historically. And this one is on documentation time. This is a big one for us because that's a huge contributor to burnout. So this graph looks at what's their average time to sign off note, standard deviation, what's their median time. This actually gives them a distribution because average, if we want to geek out a little bit, average means absolutely nothing when your standard deviation is exactly as big as your average. And why is it? Because you have skewed data. So maybe we want to look at median. So why is my average 20 and my median 12? Because I have some up at 200 days to sign off your note. Those outliers are really killing you. Can you remember anything at 200 days? No, you can't. So we can give them this big graph and say, well, your evals typically take this long to sign off. Your daily notes are the black ones. They take this long to sign off. More at the heart of what we're looking at, that's not a problem for most of our therapists. This is the bigger one we're trying to tackle now. What time of day are you signing your note off? This is the pajama time problem. So we compared this graph with this graph. This is the graph of when your patients come in. You don't have many patients at lunch, not many patients at the beginning and the end of the day. Yet this individual does the vast majority of their charting at night. This is someone where the MAT team is going to reach out to them right away and say, look, 2 things. 1, you're above the average by a lot from the standard of your clinic and more by the company. But we probably suspect you're pretty burdened with your documentation. How can we help you? And so again, that's down to the empathetic focus. This is just a little closer view of that. Last thing here is this really is that transformation office. So how do we put all this together? This looks very much like the infographic you guys have on the website, right? but a little bit different. So we have people and culture, we have processes and tools, or you can say technology. At the middle is organizational change, or you could put informatics, but informaticists are the change leaders. But what we do, so this is what Kellen, who works for me, is on the call today, is helping us to develop. There's a lot of stuff on this infographic on the right, but look at the blue, red, and yellow rectangles. Basically, there's an initiation step. So when somebody in the organization says we should do such and such, we're going to take that probable project or possible project through an initiation process where we orient ourselves to it, we ask some questions, we prioritize it, we analyze it. There's a planning phase. So if we think it's going to make it in, how might we do it? And then there's going to be a building phase. And then most important is in the middle, how do you take that information, take it back and centrally store it so you can learn from it the next time? Again, I didn't create this myself. This is a standard process we work through. We used a lot of the Intermountain process that we learned from them to learn from this and create. But the idea is just, it's a learning loop. Any learning health organization would have to do the same kind of process. And last thing is, at the end of the day, as informaticists, if we take one thing away from my talk here, in an organization, if you're going to get folks to do something, or you're going to commit your limited resources to it, you need to do something like this Eisenhower matrix to understand what's the value of the project that you're going to undertake and what's the effort associated with it. We would love to pick off all those things of very low effort and very high value as fast as possible. The problem is we start wasting our time with these things with very high effort and questionable value. That sucks our resources away, so we don't have resources available to do those things that would have higher impact and probably even be easier to do. But how do you do that systematically? Like I told you at the beginning, we've not solved for it. It's been a 10-year journey for us, but we are closer now than ever before. We have a consultant group helping us to build this out because we are committed. If we can't solve for this problem, we're in trouble as technology comes, because it's just going to keep burying us with more and more projects that we don't have the resources to deal with. So that's all I have. I'll stop here and then definitely open it up for any comments.
Yeah. Wow. I need a little bit of metadata to comprehend all the stuff that you just presented, Chris. Thank you so much. I'm gonna address first question by Kelly. What EHR are you using? Would you be able to share?
Yeah, so we use Athena Health. We've been using them for about 10 years now. We made the decision 10 years ago that we were not going to use a PT boutique EMR for two reasons. One, getting the data out was not going to work for us. We are a data hungry organization and we could not get the data easily out of most EMRs that we looked at. And two, and most importantly, is interoperability. So we right now, for near 90% of our patients, when they come in, we have their complete medical record before they get in. So we have their summary of care documents from all their visits, we have their vitals, we have their medications. So we don't have to waste our time burdening the patient asking for that again. So leveraging interoperability and leveraging the data consumption for us were big factors.
That's great. Wow. Any other questions?
I have a question, just if you can talk about it a little bit more. And it was way back at the very beginning when you talked about the diamond on top of the other piece there. When you are describing that, it all makes complete sense, and I follow it, right? And it's pretty interesting. There's two things with it. You said part of it came from a certain person, and I didn't hear who that was, and I wanted to check that further.
Yeah, so Harold Levitt, so he was the one that did kind of the first Sociotechnical simple diamond. So but there's been other versions. So the UTAU, the technology acceptance model, those are all extensions of that very simplified diamond that Levitt gave in the 60s.
Mm-hmm.
So the second question I have about that, and Kyle can maybe add in, but do you use this and show it within your department quite a bit? So I've not seen that with the diamond around it. I really like the concept, and I'm thinking how to share that further internally, and just curious how you do that.
Yeah, so it depends on the audience, but for informaticists, I pushed it a ton because I didn't understand that first. Most informaticists know Chuck Friedman's the person plus the computer is better than the person alone. But again, where I was moved just through being punched in the face in my master's was that Yes, but it's actually the ecosystem around it. So we show this to our systems department a lot because they're going to get really hung up on, I need to do this. I need to get this software out there. I need to, and you're like, why? Can you understand the person that does? So we will show this to that group a bunch. Our PTs don't care so much, so I don't show it to them. So informaticists and systems people, we see it a lot because they just need to be reminded that you're doing this for a living organization.
Thank you.
Thank you. And Ching, I wanted to acknowledge you had your hands up. Do you still have a question that we can field?
Yeah, I did. Thank you so much for the presentation. I appreciate it. It's really like impressive. And my question is, what's your thought? Because we actually use the model you mentioned about like a acceptance of the technology, like UTA,
Yeah.
use it to create our survey question to look at like people use ChatGPT in our DPT education and trying to get some understanding about acceptance for using ChatGPT in PT education. So my question is like, this is a different, correct me if I'm wrong, it's different because the social influence is so huge. And also the task is different, effort to learn is different. So I'm just curious about your opinion of using those models to understand adoptance or acceptance for ChatGPT would be different than other technology,
Well,
or how often we should track their like the change, like because we give the survey, look at the data right now, I'm assuming like a semester later it's going to be totally different. So that's my try to understand like how we better understand this situation, adopt the ChatGPT in DPT education.
Yeah, this is where structural equation modeling is really powerful because that model, so you have a standard set of questions to get those key UTAUT factors. That is used at any technology, consumer-based technology, all the way back to inside of industry, whether someone's going to use it, an employee will use it. So you could take those same set of UTAUT questions and just insert ChatGPT. I think ChatGPT will be easy to use, blah, blah, blah. And then run it through structured equation modeling, and you're going to get all your coefficients, and you can compare that to how the model has run in the literature. What you're doing now is you're saying, does it work in this contextual setting? That's just typical research. That's normal. But what's interesting about structured equation modeling is then through a qualitative piece, you could talk with folks, and this is what I did, to say, can you find some key factors about ChatGPT that you think mediate or moderate those other effect factors? And then you can test it. You can ask the questions. Now you have that data. And now in structured equation modeling, I can say, does it predict the behavioral intention alone, or does it maybe mediate one of the other ones? And I can change the model and see the impact of those factors that you found through qualitative research on the model. So that's just another way to empirically test how well it's working in practice. So, but I think simple version would be just ask the survey for UTAUT, measure it in an R-squared. You could run that in Stata even. They have a pretty easy version. But if you want to mess with the model, it's a little more integrated, but anyone with a little knowledge of some basic machine learning can do that.
Great. We have one more question from Stephen Hunter. Of all the human factors that motivate PT to change behavior, we do that every day in our practice. Which one do you think are the most influential? And are they different between PTs and other professionals?
Yeah, no, that's a great question.
Yeah.
I really want to know Stephen's thought too.
Yes.
I stole a lot of this from Intermountain Health, so maybe I'll give him a chance to share. In my research, and at least what I'm finding, is facilitating factors are huge. So if we rely just on the person's native, how they are wound, we leave it to the whim of chance oftentimes, right? But if we can really focus on understanding the pressures on them and then put facilitating factors, for instance, if I give them a crummy computer, they can really want to use it. The technology is awesome, but the computer takes 12 minutes to boot up. They're not going to use it. I just block them. By contrast, if I give them time to use the technology, I incentivize them to use whatever it is I want them to use, I can move their behavior. This is just social economics 101. So in my impression, it's actually us focusing on facilitating factors more than anything. And my research played that out too. But I'm really interested in what Stephen has found because he does this every day.
Yeah. Stephen, not to put you on the spot, but if you're willing to share.
No, I mean, I agree. I think I agree with Chris. I think he's done great. His research and his PhD have been really, really helpful, I think, to bring in that component of how to support people and make it easy for them to do the right thing. And I think he's right. I mean, I think there's human factors of motivation and other things that you can influence to some degree, and I think what he's laid out is to really set a vision and then set up the processes so it's easy to do it right and it's difficult to do it wrong. Yeah, I'm in a program right now, internal program for Intermountain, and they actually set up the EMR to make it difficult to do things the wrong way. So they intentionally, for physicians and therapists, say, look, if you're going to do something that we don't think is the right way or is not the right way, then you're going to have to jump through 3 or 4 or 5 clicks. But it's one click to really do it the right way. And this really follows a lot of, I think, Chris's research. So yeah, I think I would agree with what Chris said, and that's great presentation.
Yeah.
Like Sam said, I'm going to have to look at your slides and take a couple hours to really go through all the thought process. There's a lot you did to prepare for this. Thanks.
Yeah. Maybe I can propose like part 2 sometime later this year, or maybe down the line, Chris. I really appreciate your insights. I think about systems thinking and a lot of things that what you're saying, and we're trying to foster that in our residents and our faculty mentors. But this has been really great. And I'm sorry, Brad, your question is really good too. How much information patient can handle? What are kind of the, how do you communicate that? I know we're interested time, we're at top of the hour. Maybe we can sidebar that question to Chris directly.
Yeah, shoot me an email. I'm happy to
Yeah.
take it offline. That'd be great.
Yeah, thank you so much on behalf of IRC team and the community. This is recorded and we'll put it on our website, and we'll let everyone know about the next July session. We'll communicate via email. You will get something from us. Have a wonderful rest of the day, and thank you so much, Chris, once again.
Great. Thanks, guys.
Thanks, everybody.
Bye-bye.